Welcome to Catholic Comments. I'm John O'Keefe.
I am Wendy M. Wright. Our guest today is Dr. Amy Haddad. Dr. Haddad is the director of the Center for Health Policy and Ethics at Creighton University. She holds as well an endowed chair, the Dr. C.C. and Mabel L. Criss Endowed Chair in Health Sciences here at Creighton. And she's here to talk with us about the Center for Health Policy and Ethics and its role in the changing world of Catholic healthcare. Welcome.
Thank you.
It's good to have you finally on the program, Amy. And what I want to do first is just get a sense of what the Center for Health Policy and Ethics is doing here at Creighton. What's its basic mission and purpose?
Thank you. The center was established in 1984 when the university sold St. Joseph's Hospital to a for-profit system. And part of the sale at that time was to establish a Center for Health Policy and Ethics. And so I'm the third director of the center, but from its inception, we've always been multidisciplinary and interdisciplinary. So we have physicians, nurses, philosophers, and a mix of people with, most of us have a foot in more than one area. We teach in the health sciences at Creighton in all of the professional programs, and as Creighton has developed new programs, we've been part of that in teaching the ethics content. And we've also been involved in clinical ethics over the years through our contractual and collaborative arrangements with different Catholic health systems. Some locally, we've worked with Allegiant before it was part of Catholic Health Initiatives, which it is today, and we continue that relationship. We've worked with Catholic Health Initiatives actually at the national level with their corporate offices in Denver on different issues with ethics committees for their system. And we've also worked with what is now Dignity Health, but previously was Catholic Healthcare West on the West Coast and as far east as Phoenix and Arizona.
So
before you ask that question, Wendy, there's one I want to throw in here. Just back to the founding. Was part of the purpose driven by a concern that if we made the hospital for-profit, the ethical concerns might not be front and center? So
Yes.
Was this a way to make sure that they didn't get lost?
It was.
Okay, thanks. So, Wendy, go ahead.
Yes, I was going to say, you've described teaching, probably thinking through ethical issues that emerge in healthcare, but exactly how do you function in terms of these relationships with these different healthcare systems? I mean, what kind of relationship is that?
Well, many of these systems at a hospital level, so let's say a system has like maybe 10 hospitals in their system or more. Each of the hospitals in the system will have its own ethics committee, let's say, where they develop policies, where they do training and education for their people, where they work on ethics consultations. So when we work at a system level, we help them think through how they're going to do this in an efficient and consistent way across all of the hospitals in their system. So some have rural hospitals, some have large hospitals, and so what works for a hospital of, let's say, 50 beds or 100 beds really is very different than one that has 500 beds. So we work at the level of what will make sense at a system level and also to help reduce inefficiencies in like developing policies and things like that so that they can do it once and then make it adaptable to the rest of the institutions in their system. And all of that is, in hospital settings, is based on the ethical and religious directives that the American bishops have written. And so we use those as a base for many of the policies that in the past we would help them develop, though as things move along, there's changes.
So I think a lot of people might not even be aware that the American bishops have health policies or ethical guidelines. I mean, what are some, maybe besides the obvious one about abortion, but what would be some other kinds of problems that might be addressed in those directives?
By the way, the directives are available on the American Bishops' website, so anybody can go and look at them and see, but they're really very rich. They're introductions to major categories of health issues to which the bishops wish to speak. So there is an introduction to the whole set of directives, and then the first part is the beginning of life. So there's all the different kinds of directives that would have to do with, and as you mentioned, as contraception, abortion, things like that come up right away. But there's lots of other issues at the beginning of life that are addressed in the directives. And they're literally like 1, 2, 3, there's numbers in there. Some people become so skilled at knowing what the directives are that they'll quote them by the number and things like that. I'm not one of those people, but they're very easy to use. And then, of course, at the end of it, they have at the end of life. And so they have all those directives that would deal with end-of-life decisions. But there's some beautiful language in it around justice issues and just the healing ministry of Jesus, all the different places in the Scripture that we have evidence of Christ ministering to people who are ill or dying, and using that. I think that's the part of the directives that gets ignored a lot. And it's so important for people who are working in Catholic healthcare settings to understand the connection back to the actual ministry of Christ.
Yeah, I was going to say, people, it's pretty high profile to think about both beginning and end of life issues, or those are the Catholic issues. But in fact, you've brought up the question of distributive justice. Who has access to health care? Who's left out? How do people think about that? Health care is, that's a real can of worms in terms of how do Catholic hospitals think about somebody coming in to the door without insurance, or somebody who can't stay long, or whose insurance won't let them stay long and they need more help? What are those kind of issues that get raised by these directives?
I don't think you'd be surprised at what's in the justice part of it, but there's a lot left unanswered.
Okay.
The devil in the details, that there should be preferential treatment for the poor, but how you work that out and maintain an institution, that no money, no mission sort of thing that you hear often, is what comes up in Catholic healthcare a lot. If we give all of our care to people who can't pay, then how will we pay our employees? How will we do any of the things that we need to do? So how do you find that balance? And I don't know that there's a standard way. In our interactions with different institutions, they're struggling with things also, not just care for patients, but the justice of things like layoffs. How many people do you keep? And if your census goes down, how do you accommodate that? And do you keep people on call? And do they get paid for being on call? And there's just a whole lot of different ways that people are trying to figure out, if we stay in business, how can we stay in business and still keep our Catholic identity?
I think that's a really good question. And I'm kind of struck by your reference to the healing ministry of Jesus. And because I don't really pay that much attention to the healthcare world. In fact, I try to avoid it, because I just don't like things medical. But, when you think back on the founding of these hospitals, that's what they were doing. And so many of the people that worked in these institutions were religious, just like in Catholic schools, and they worked basically for free. Mm-hmm. So how is the changing economics of healthcare in America impacting the Catholic system's ability to continue the healing ministry of Jesus, do you think?
I think that's a huge challenge. I don't have a great answer for that right now, but the idea of looking exactly like for-profit institutions, they're always vilified, right? Because they're making money for their shareholders. But even not-for-profit institutions and not-for-profit, non-faith-based institutions are all starting to look very much like for-profit institutions. So the bottom line, looking at their, this is my view, looking at their budgets and how they use their resources, I wouldn't see much difference. It might be, I used to dream about this. I would think, well, if I was, I'm a Catholic hospital administrator, I would want to somehow get out to people. And I never found a good way to market this, because, see, it's all about marketing now. But if you're dying, this is where you should come. Well, you would never see an ad for a hospital. If you're dying, this is where you should come, unless you're going to be cured.
Right.
But certainly we would have more to offer with a faith tradition and our belief that this is not the end of life, but eternal life awaits us, wouldn't we be the best at witnessing people's journey from life to death? So I'm using that as an example of how a Catholic institution, it doesn't take care of the money issues, but it would set Catholic institutions apart in that we have something more to offer patients and families than just state-of-the-art medical care. I mean, everybody should be doing that.
But it seems like that might even be something that should be incorporated into medical school curriculum at Catholic medical schools about, those kinds of questions. Don't you think about, I mean, how do you shepherd a person through life as part of your ministry as a physician? And this really is the whole health industry in some ways.
Yes. I don't think anybody's doing a really good job with it, obviously. I mean, we have a real hard time with accepting death in the United States. One of our faculty members, Helen Chappell, is a wonderful thanatologist and looks at end-of-life issues. And
a death specialist?
Yes, a death specialist. And the whole focus on rescue in our healthcare system is so strong, and everything is structured for that to go against that in some way. And hospice, as an example of a place where people can go when they are dying, it barely has a toehold. And it's been around for a long time in the United States. So there's just so much work to be done. I mean, that's just one area. Other things like offering to Catholic patients who want them sacraments when they're in the hospital. I mean, those are things that I would think would be pretty easy for us to do with lay ministers. I mean, granted, there might
chaplains. I mean,
right.
Don't you have chaplain staffs?
Well, there are, but it doesn't seem to be. It seems to be like a also ran, in my view. I mean, oftentimes chaplain departments aren't staffed as well as they might be in a lot of places.
It's a bottom line issue again, isn't it?
Right,
yeah.
right.
Mm-hmm.
Well, let's circle back to some of the things you were saying about your own work in the center about health policy. And you had said that you do clinical ethics, or clinical ethics.
Yes.
What is clinical ethics?
Clinical ethics would be applying. It would be applied ethics in a clinical setting. So you could do applied ethics in law, engineering, whatever. So clinical ethics is. I don't like to use the terminology medical ethics because there's more than physicians in healthcare. So it's the clinical side of the application.
Would that be
ethics.
something like, a person's on a breathing tube and has no brain activity, and you have to decide what to do?
That's an extreme example.
An extreme example, but that's a clinical situation with a real big ethical problem, right?
Right.
Yeah.
Or let's take something more commonplace. The whole major issue of errors in the hospital. The underpinning of that is really ethical issues, right? How honest are you going to be about it? Are you going to be punished if you report an error? How do we deal with this? How do we set up situations so people don't have to be heroic in reporting when there's a problem or an error? So ethics undergirds a lot of what goes on in healthcare on a daily basis. And most of our work is to help people raise enough awareness so that they say, oh, okay, I see this is an ethical issue, and that there are some tools or resources for them to go to so that they can get some help in figuring out how to resolve it.
Yeah, you made the comment earlier, this is fascinating, that often in the contemporary world, with such advances in technology or pharmacology and things like that, that even the ethical directives of the bishops or of individual hospitals or hospital systems don't get down to the brass tacks. They don't have a directive to accommodate something new that has come up. And you gave the example of pharmaceuticals that are.
Right.
Can you share that?
There's a lot of drugs coming out now that are biologically targeted, so that rather than giving a drug and just kind of hitting the broadside of a barn, these drugs will be targeted to certain patients, even going so far now as a genetic makeup matching the action of the drug. So we're getting really good at doing this. They are outrageously expensive, and so you get down to which patients and then for what benefit. So if a drug costs $100,000 and I can give somebody who matches perfectly with the profile for the drug an additional 3 months of life, should we do this? And this is not going to be the only patient. And I need money for drugs of the more garden variety for all the people who need like control of their high blood pressure or diabetes or things that...
Who are going to live a lot longer than 3
Right.
months.
Right. So how do, and there aren't committees that make these decisions per se. There's a, it's P&T. No, I won't remember the exactly. Something in therapeutics. This is terrible. My pharmacy colleagues would be very disappointed in me. But they make decisions. It's made up of physicians and pharmacists in the hospital, and they decide which drugs they're going to carry and which ones they're not. And so you have those discussions, but that doesn't mean that they end there, because a physician could say, well, I need this for my patient, and they make a case for it. And then it's up to administrators at the hospital to look at not just the drug budget, but the budget for the whole institution. And where does this all fit in there?
These are really complicated problems, and maybe we should have you back sometime. But I don't want to let you go without you talking a little bit about this podcast initiative that you have at the center. Can you tell us about that?
Yes, we're excited, and it's been lovely to get to experience the whole process of developing it. We see healthcare in the future, based on a lot of data in the literature on healthcare, that it will be delivered in an outpatient setting, that more and more hospitals are going to be for very acutely, seriously ill patients, and that many things can be taken care of in an outpatient setting, from surgery to rehabilitation or whatever. We don't have any kind of system of dealing with ethical issues in an outpatient setting. And many people who work in outpatient settings are geographically dispersed. They don't have a lot of people to talk to about issues that they find out, that are troubling them in practice. And so we're trying to do a series of podcasts with people who work in outpatient settings. And the main point right now is just to raise awareness. Yes, the things that you are concerned about or that you take home at night and wonder about later on are ethical issues. And there may be some tools or ways to think about it that would help in resolving them. And I think just some comfort in the fact that you're not alone in worrying about these kinds of issues.
Now, what's the name of the podcast, and how can people find it?
Bioethics Beyond the Bedside. So it's triple B.
And there's a link to it on your website?
There is.
And we'll certainly put a link to it on the website side of this podcast.
Lovely. Thank you.
This has been a fascinating conversation, a very preliminary conversation for a very rich and complex topic with Dr. Amy Haddad, who is the director of the Center for Health Policy and Ethics at Creighton University. Thank you for being with us.
Thank you.
And this has been Catholic Comments from Creighton University.